Hello, hello, how are you?
I'm good. How are you?
It is possible to open your camera.
Yes. Can you see me?
Yes, hello.
Hi, how are you?
Everything is okay.
Yes, everything is okay.
I hope that you are preparing in the best way.
I'm trying my best.
Okay, don't worry. I feel
Yeah.
that you are anxious and irritable. Yes,
Sorry?
I feel that you are irritable, some sort of irritability.
Sorry, I didn't get it. Rateability for what?
Yeah, I feel that you are irritable at the moment.
Yes.
You can't take Muscovy. You can't take it.
Thank you so much. Thank you.
Okay, just 1 minute waiting for Dr. Mahmoud.
It
And
sounds good.
Dr. Muhammad came late because in beauty at the time, but
Okay.
late at the end of the exam, Dr. Muhammad will discuss with you 4 stations as
Okay.
the last 4 stations of Dr. Muhammad. Okay?
Okay. Sounds good. No
So
problem.
only 1 minute. Wait for Dr. Mahmoud come. Okay?
Sounds good. Sounds good.
Prepare yourself.
Yes.
Prepare your water.
I have it. Just
Because like the real exam, we will start
yes.
by 7 stations. And
Yes.
then after
Yes.
that break about 15 to 20 minutes, then
Okay.
we continue the next 7 stations. Okay?
Okay. Just give me a minute. Just give me a minute.
Okay.
Yes, I am here. Just give me a minute.
Yeah.
Okay. I think you can see me. Yes.
Second is waiting for Dr. Mahmoud.
Yeah, no problem. No problem. So, Dr. Thurwood, are you based in Saudi Arabia?
Yes.
Oh, I was there like a month ago. I was there for Umrah.
Wallahi, Umrah, mashallah.
Yeah,
When?
I
You came after
last
1 month? You came or already do Umrah?
I already did it. I was there a month ago.
Okay, excellent. Very good. I am in
Yeah.
Mecca. I am in Mecca.
Oh, that's so nice. That's so great.
Beside the Haram, between the distance between me to Haram,
Oh,
about 10 minutes by the car.
oh, that's so great.
I
That,
am,
you're so lucky.
yeah,
So,
I'm working in the Umukura University.
oh, that's nice. So whenever you want to directly talk to Allah, you can just go there. And,
Please, I want to confirm your name. Your name?
uh, Maria?
Maria.
Yes.
Yes, excellent.
Yeah, my name is like Maria, Pulwasha. Both are my names, so you can call me whatever you're
I
convenient
call you
with.
Maria. Maria, it is better.
That's a lot easier as compared to the other one.
Yeah, yes.
So let's see what I can do.
لماذا سمي شهر رجب بشهر رجب؟ باسم رجب على اسم سيدنا رجب. You have any problem? Okay, okay. I will admit you now. Okay. Dr. Mahmoud, how are you? Dr. Mahmoud. Dr. Mahmoud.
Hello.
Assalamu alaikum.
Alaikum salam. How are you, Dr. Server?
Fine. You can open your camera, please.
Okay, give me one moment, please.
Yeah. Yeah, Dr. Mahmoud. Okay.
Hi, Dr. Mahmoud. How are you?
Hi, Dr. Maria. Fine. Alhamdulillah. How are you?
I'm doing well.
Are you prepared well for the exam?
Kind of.
Don't worry. Make it easy. You will go to pass. Put on your mind you will pass.
Yes,
And you will
inshallah.
pass.
Inshallah.
Okay, Dr. Maria, Dr. Mahmoud, welcome. So now
Thank
we'll
you.
start this exam. This is the first task, Dr. Maria.
Okay. So just a quick question. Will I be able to see the timer, or I should just time it by myself?
Yes,
Like,
you have 2 minutes. I will count the minutes for you, and I go to you to start. So
okay.
you have 2 minutes from now.
Okay.
These 2 slides.
Okay.
The screen is visible. Good.
Yeah, it's good.
Before time finish, I will inform you 1 minute in the preparing time and 2 minutes at the end of the 10 minutes.
Okay.
You understand?
Sounds good. Thank you. Next page, please.
Okay.
Thank you for enlarging it. Can I see the first page?
Okay.
The previous page, yeah. So I have ST2, ST5, anesthesia.
Till 30 seconds remaining.
Okay. Please, next page.
Okay.
Okay.
Okay, start.
Okay. So first of all, I am taking the over at 9 a.m. I know about my staff, and I'll be assigned the rooms based on their competencies. For all the room, I would like to get an access to their notes, and also rule out any drug allergy.
So, Dr. Maria, first, I will expecting from you to triage the cases and justify your management and delegate the tasks to every one of your staff. Please, you can start.
Okay. So I'm taking the IMST5. I'm taking the over at 9 a.m. I know my staff, and based on competencies, I'll delegate the rooms. And also for each room, I will for each case, I would like to take get an access to operative their notes, and then rule out any drug allergy or any other allergies. Also VT risk assessment. The patient safety would be my first priority, and I will go room wise and do as urgent, semi-urgent, and non-urgent, and in the end I'll do prioritization. So the first room, this is twin pregnancy, and she has regular contraction. For this one, I would like to send one of my midwife to check the fetal heart rate. And first of all, I would ask her to check the ultrasound. What is the presentation of first baby if it's cephalic?
The first is cephalic.
Yes, first is cephalic. The midwife, I would assign this case to the midwife, and this would be my semi-urgent case. And there would be continuous CTG monitoring, and also
It's a semi-urgent case. Semi-urgent.
yes, semi-urgent case. And also I would tell her to be vigilant about the second twin, and also active management of third stage, because these patients are at the risk of PPH. And also involve the pediatrician. 2 cots should be available. So the next case is induction of labor and gestational diabetes on insulin. For this case, that would be also semi-urgent case, because she's waiting for ARM. I would like to send one of my midwife to this room, and because she's here for induction, her fetal heart can be checked, her insulin, she's on insulin, her blood glucose can be checked, and control her bishop scoring can be done, and control ARM can be done. And we will be continuously do the continuous fetal monitoring for this patient.
The semi-urgent also?
Yes. And this third case, it is I would like to see, because this patient has certain risk factor. Her BMI is high, she is fully dilated for 3 hours, and she has pathological CTG. So for this patient, this would be one of the urgent case. And for this one, I would like to send my ST. I would like to send my ST. I would like to go by myself, because the CTG is pathological and she's been pushing. So for this patient, I would like to see if the delivery is imminent or not, and also if we can do any instrumentation.
The cervix is fully dilated, but head not bulbal per abdomen.
Sorry?
The cervix is fully dilated.
Okay, cervix is fully dilated. So
Yeah.
I would like to see the presentation of the head. If it's
the presentation says right occipital posterior just below ischial spine.
Just below ischial spine. So I would like to see if I can use a rotational forceps for this one, and if it would be successful, I would assess. And if it's not, if I assess the patient, and if I feel like that the delivery is not imminent, so we can go with the cesarean section as well, by informing the operating room. But I have to assess her, and I would also see that what is the pathology in CTG, and after and then the next room is von Willebrand PPH, 30 minutes retained placenta. This is one of the emergency case, and for this one I would like to go by myself because it's a retained placenta. We have to group and cross match, arrange the blood for this particular patient. We have also the placenta is retained for 30 minutes. So the patient would be shifted to the OT, and then we will see like if the placenta can be delivered. If not, then we will involve the anesthetist, and then we can remove go for the manual removal, and after that we will debrief the patient, antibiotics, painkillers, and a syntocinon drip, oxytocin 40 international unit would be given to her, and then we will watch her for any signs of PPH. Then the third case is previous cesarean section and contracting 3 times in 10 minutes. So this would be one of the semi-urgent case. I would like to send my ST2 to check, to take a brief history, informed consent, and we will prepare her for cesarean section. We will inform our operating room team, anesthesia, cross-match, baseline investigation would be done. So this would be my semi-urgent case. Then low risk pregnancy and undiagnosed breech. So she's 9 centimeter, was at 8:30. Now it's 9 o'clock. So this would be one of the urgent case because I will reassess the patient. Maybe she's fully dilated now, and I will inform the patient about risk versus benefit of assisted vaginal breech versus cesarean section, because emergency cesarean section also pose more risk. So we might have to do assisted breech delivery for this patient, and pros and cons of both the cases to the patient. I'll explain it. And then for the next room, it would be my routine case or non-urgent case, prematurity, vaginal birth at 4. I will send one of my midwife to this room, and to assess her. She already had vaginal birth, right? This case number 7. Okay, so I would like to assess her that if she has any signs of PPH, any other problems, then we can transfer
Amount
her.
of blood, 200 ml.
Okay, that's fine. We will keep her watching. If she has any pain, we will give her pain relief and see everything is going okay. And then this last case, it would be also one of the urgent case because her BP is 180, 110. So I would like to go by myself in this room. Because her fetal, she has also, I would like to do her urinary protein. So for this case, the resuscitation, assessment, investigation, and treatment will go side by side.
What investigation you want to know?
So investigation urinary protein, I would like to know.
Plus 3 proteinuria. Plus 3 proteinuria.
Okay, plus 3, and I would like to clinically assess her if she has any signs of impending preeclampsia. If that is the case, then I would also like to give her magnesium sulfate, and also there is no fetal heart rate. I would like to do real-time ultrasound to confirm that if there is heartbeat or not.
Ultrasound confirm for small baby and demise baby, demise.
Okay, and I would also like to rule any sign of placental abruption.
1 minute remaining.
Okay, and for this patient, I would like to go with the first line management, and including oral labetalol. Then we can give nifedipine or IV hydrolysine. And investigation, I would like to do full blood count, LFT, serum urea electrolyte coagulation profile as well, and then check her blood pressure after every 15 minutes. And I would also will be breaking the bad news for fetal demise as well.
So what is the category of this case?
And this is an urgent case.
Okay.
And in the end, I would like to do the VT risk assessment for all the patient and address all the concern if patient have. And for case number 5, as she is previous 3 cesarean section, so during the surgery, I would involve my consultant as well.
Time finish.
Time
Okay.
finish.
Thank you.
Okay. Thank you, Dr. Maria. A lot of thanks.
Thank you.
But first, I wanted to mention some important points
Sure.
related to this task. You are lost time first when you put an agenda overall. So you start immediately and don't start before the examiner ask you.
Okay.
Just when you enter the session, just hello,
Okay.
and that's enough.
Okay.
And then I ask you, I expecting from you to triage the cases and justify your management and delegate the task, whatever the questions by the examiner. So you don't speak before the examiner asking you. That's very step. Okay.
Sure. Sure.
Yes.
Thank you.
When you are telling overall, I will take review the notes. Yes, apply this on room by room. So you can start by I will my approach. I will go room by room, and I change my priority. I will moving from room to room.
Okay.
Okay. So relate to the first room, for example. Don't ask me late ask me what is the ultrasound finding. So every information you have, that is little informations, not enough information to decide what is the category of every room. So you must ask the examiner about the information needed to help you to decide which is urgent, which is semi-urgent, which is routine.
Okay.
You must ask specific informations. So this room, twin pregnancy, contraction 3 and 10. Now,
Yes.
what is the ultrasound finding? Yes, twin first one cephalic. What other information needed to decide to help you to decide the category? Don't ask me about the membrane is intact or not. Don't ask me the cervix was dilated, how many cm dilated. What about the fetal heart is heard or not? It's very important patient safety here because this patient 26 weeks. 26 weeks. What do you want to ask? Patient safety here.
26. I missed this 26, I think. Yes.
Yes. Now I tell you 26. What is the important information you want to ask?
So in this case, we have to ensure that if we have neonatal ICU because the patient.
Excellent. Yes. So
and we have to have two cots, two pediatricians.
If you ask me, I tell you neonatal unit full, and there is no bed in hospital. So what is your next action?
Intrauterine transfer if the patient mother is willing, and we have to do her vaginal examination. If she's in the condition for IT intrauterine transfer, then we might have to go for that.
So it is category now. It is semi-urgent or urgent?
It's urgent. It's urgent now.
Okay, so you understand now?
Yes.
You must ask about from the examiner. The examiner not volunteer to give you informations. The examiner don't give any information except you ask. Except you ask what the information needed specifically.
Yes.
Okay. So now you change your mind. That is high priority. I can give this patient glycolysis, diflunisal or atisuban, steroids, magnesium sulfate, and arrange for intrauterine transfer. It is a high priority case.
Yes.
Okay.
Yes.
Okay. Yes. So next room. Next room also, this is routine, CTG normal. Don't ask me about the CTG of this patient.
Okay.
The CTG is normal, so it is a routine case. You can send the midwife to counsel and apologize the patient. And this patient will need, because his patient diabetes mellitus insulin, this patient needs a sliding scale of insulin on lab. Okay?
Yes.
Okay. Now the third room, also don't ask me about the some details except after prompting you. So it is very important to ask this patient now pathological CTG fully dilated from 6. So now 9, 3 hours. Yes. So what about the presentation? It is cephalic, right? Occipital posterior. It is fully dilated and the head below ischial spine. So it is, and this patient is candidate for what?
This patient, either we can use forceps or we can go for cesarean section.
Rotational, yes, rotational.
Yeah,
Rotational.
for rotation forceps.
Mid
That's what I said.
cavity,
Yeah.
mid cavity forceps. So trial of mid cavity must be done in the theater after
Yes.
written consent, very important,
Yes.
and the
Yes.
count the patient about the high failure rate of this rotational instrumental delivery, and
Yes.
ask the theater team and all the staff to prepare all the recourses for cesarean section, because the
Yes.
failure rate is high. And
Yes.
you don't forget this patient need instance report. When you do
What?
instance report when doing instrumental delivery,
Answer. Yes.
cavity
Answer.
instance report, and reassess her in the theater prior to decision making for the mode of birth. This is a high priority case.
Okay. So why we need incident reporting for this case?
Yes, if use mid cavity forceps.
Yes, if it's failed. Yes, of
Okay,
course. Yes.
okay.
Yes.
Okay. Now the follow brand disease. Also, don't ask me about this patient had previous BPH. This is two risk factor: previous BPH and
Yes.
follow brand disease. Follow
Yes.
brand disease, previous BPH. So this patient high risk for BPH. So you must ask me now, what is the amount of blood loss at the moment?
Okay.
I will answering you. The blood loss is 1.5 liter currently, and in continuing. So what is the observation at the moment? What is the vital signs at the moment? You must ask me about this.
Okay.
And
So, Dr. Thurvard, I have to ask you, like, I would like to assess for the blood, and then you'll tell me, like,
yes,
how
you
much blood.
assess and ask. Don't ask.
Okay.
What is the amount of blood loss at the moment?
Okay. Okay.
Why? Because this finding also, this is a high priority case, and you are answering about the most important points. But
Yes.
this is the information gathering in such task.
Yes.
So this is a case of BPH. We'll do the major hemorrhage protocol, IV access, fluid, anesthetist here. Very important, the role of anesthetist in this
Yes.
patient to insert two IV lines. Okay, activate massive hemorrhage protocol. And it's very important because this patient has follow brand disease.
Factor should be more
Call for help.
more than 5. Yeah, call for help.
Who is calling?
A hematologist.
Yes, you must contact hematologist in such case. And you are forgetting consultant in every cases, except in one case. After the 5 cases, you tell I will involve my consultant. This room, you must involve your consultant in every urgent case. Any pathological CTG, you must involve the consultant. If any bleeding, you must involve the consultant. Okay, you are forgetting to involve the consultant. It is patient safety.
Okay.
And the communication with the colleague. Okay.
Okay.
Okay. Then also room number 6, instance report, undiagnosed breach. Undiagnosed breach, we need instance report. The last case is number 8. Okay, room number 8. It is a high priority one.
Yes.
Also, important to need another second opinion to confirm the IOD.
Okay.
Okay.
Yes.
Yes. And then after establishment of the case, because this patient has severe hypertension, this patient also need IV access, full protocol for investigations, full blood count, uroelectrolyte, liver functions, coagulation studies, and then this patient I give labetalol if there is no contraindications of labetalol. Okay, IV magnesium sulfate to control the eclampsia, prophylaxis against convulsions, and second opinion scan, very important to confirm IOD. After establishing the case, consider how to expedite birth, and the aim is vaginal birth. It is a high priority case.
Yes.
So we can summarize your answers. You answer about 3 questions in this task. First of all, what is the urgency of this case? The urgency is either urgent, semi-urgent, or routine. To reach to this diagnosis, you must ask the examiner about the hidden information to help you to reach to this decision. So it is urgent, semi-urgent, or routine according to the data in front of you and the data asking the examiner about it. This is number one.
Yes.
Number two, what is the task? And who will do the task?
Yes. Yes.
Okay, put all of this in your mind to answer this station. It is a very simple stations. Don't be panic, okay? And it is natural as in your routine work in the hospital.
Yes. Yes.
Okay. Any
And
questions?
yes, I have a question. So, Dr. Thabit, because I got this, like, I've been trying to do it and I've been practicing it. And to my understanding, so for example, I think, like I told you, like I gave my exam once. So the examiner asked me, like, how will you go to 3 rooms? And how your consultant would go to 2 rooms or whatever, like, and at this point we have only one anesthesia trainee and one ST2, and we have a lot of urgent cases as well. So like I understand that I cannot, because all these rooms are urgent. I understand this pathological CTG is urgent, one Willy Brandt is urgent, then this preeclampsia or eclampsia is preeclampsia is urgent.
Yes.
Then all these cases are urgent. Then I understand that my consultant can go to 1 or 2 room. I can go to 1 or 2 room.
Yes.
But so
I get your questions, but don't worry about this point. The exam to test you how to think.
Yeah. Okay. So I shouldn't worry about that.
Yeah. No. Don't worry about that. when the examiner feels that you're understanding the approach of each task, this case is urgent, semi or routine. What is the task and who will do the task according to the stuff you have? Yes. But if there are 3 urgent conditions and 3 urgent need consultant, and I have only 1 consultant, so what will you do? You can call another consultant.
Okay.
We can call another consultant. We can call another anesthetist. Yes, I have 1 anesthetist. The anesthetist can go to the room of BPH and the room of preeclampsia. I need the anesthetist in the 2 rooms. If finish the first room, you can join us in the second room.
Okay.
If you are busy in the 2 rooms at the same time and need in the 3rd room, so at this time you can call another anesthetist. Okay. So that is not a matter. The examiner, or during the exam, only the examiner you want to know you are thinking about the case, how to think, how to triage, and what's the task, and how to delegate the tasks.
Okay, now got it. I think in this labor ward for case number 1, 3, then 4, and then 6, 8. These are the cases like all urgent.
Okay, so, no problem.
Okay.
So and they will appreciate that your approach when you are going room by room. It's very important. In my opinion, also room by room, it is safer for you.
Yes, that's what I think. People say that go with urgency, but 2 minutes, I think it's not enough for me to just prioritize it, go room wise, and in the end, I'll do prioritization.
So you will start, I go room by room, and I will change my priority while moving from room by room according to the information from you.
Yes.
Okay. Any questions so far?
No question. And how would you rate me? So I can work on myself.
Overall, you did well in this case. Excellent.
Okay. And whatever you said, I'll try to incorporate it, and I'll work on all these things, because like it gave me a broader vision, and I think I need to think beyond what is even there. Just with little bit information, it's more than that.
Yes.
Thank you.
Next task, please.
Thank you.
Dr. Mahmoud, the time with us?
Yes.
Any next page, or this is the only page?
There's only 1 slide.
Okay.
Start.
Okay. Hi, I'm Dr. Iftikhar, one of the doctor in the ward today. May I confirm your name and age, please?
I'm Hannah Clark, 25.
And how would you like to be addressed?
Hannah's fine.
Okay. How are you doing, Hannah?
Fine.
Okay. Hannah, let me tell you briefly what we will be doing in this consult. I'll be asking you some questions, and we will discuss about your management plan. What do you think about it?
Yes, doctor, go ahead.
Okay, so Hannah, I understand that you had vaginal delivery and you had a tear down below. Is that correct?
Yes, doctor.
Okay, so tell me more. What's going on?
Doctor, I'm delivered very rapidly, doctor, in the hospital. Just while in my home, I feel cramps in the lower part of my tummy, and I will go to the hospital. And surprisingly, the midwife examine me, tell me I am fully dilated, and I'm surprising also I am delivered since 30 minutes. So everything go fast, doctor.
Okay. I'm so sorry that you have been through this difficult situation, but I'm here to help you and support you. How's your recovery going on, Hannah?
I'm fine, doctor. What do you want to ask me exactly, doctor?
Any pain?
What?
Do you have any pain?
Now the midwife gave me painkillers. Now I'm fine.
Okay. Any foul smelling discharge from down below?
No,
Okay. And are you taking any medication for any laxatives to avoid constipation?
I think it is written for me, doctor.
Okay, okay. Are you up and about and moving?
Yes?
Okay. Are you breastfeeding your baby?
Yeah.
Okay. Any problem with peeing?
Any problem with what?
With your waterworks or peeing?
No, no.
Okay. Okay. And okay. And are you eating well? Are you passing flatus?
Yes.
Okay. And any other problems with after the delivery?
No, doctor, just I'm average that why this happened with me and it can be happen again in the future pregnancies.
Yes, so we will be discussing about that shortly. That there is still in possibility of having this tear in future pregnancy. I know you've been through a very difficult time, but we are here to help you. And just some more question. Any problem with your stool? Any incontinence or anything?
At the moment, no, doctor.
Okay, okay. Okay. Have you ever got pregnant previously?
No, this is the first one.
Okay, okay. Congratulations on your first baby.
Thank you.
Okay. And what about your any medical condition, like
No,
high blood pressure, clots in lungs and legs, or diabetes, anything?
no, I'm fit and well.
Okay. And any allergies?
No,
Are you using any medication for prolonged period?
no,
Okay. And are you aware of your height weight ratio?
I'm not sure.
Okay, that's fine. And okay. And what about who do you live with?
With my husband.
Is he supportive?
Yeah,
Okay. And what do you do for a living?
I'm housewife.
That's great. Any low moods for 4 or more weeks?
No,
Okay. Anything else you would like to add?
no, doctor, I'm afraid about this, why this happened. I think, doctor, the midwife is not competent, doctor.
Okay.
So,
I'm so sorry to hear that, Hannah. So I want to assure you that all the staff in NHS are well trained and competent, but there are certain circumstances that complication do arise. As you mentioned that your delivery was happened very quickly, so that could be one of the possibility. You know, like if you deliver in the hospital or in midwifery-led care on home, if it's the birth is supervised by healthcare professional, you know, we keep on monitoring you. But in these circumstances, unforeseen circumstances can happen. I know it's very difficult, but you know, we are here to support you. And for your pain, we will give you painkillers, we will give you antibiotics for your better healing, and for also with the I would like to tell you that in your future pregnancy there is still a risk of like 5 to 7% of risk having this tear in future pregnancy.
So what can help me to recover, doctor?
Yes, that's what I'm going to tell you. So for your recovery, you have to be up and about, just take healthy diet, high fiber diet, and then also try to avoid any constipation, because it can worsen your condition, and it can also affect the wound healing. And we will connect you to our physiotherapist. He will help you in pelvic floor muscle training, which will strengthen your pelvic floor muscles. And also yeah, and if you have any signs, any smelly discharge, any problem with wound healing with your stitches, or any excessive pain, or any fecal incontinence, incontinence of stool, you have to come to the hospital right away.
Okay.
Am I clear so far,
Yes,
Hannah?
yes, doctor. Very clear.
Yeah. Yes, and we are here to help you. And also, if you have more questions, you know, we're here. And I would also like to let you know that 60 to 80% in 1 year, they don't have, in next 12 months, they don't have any problems. Only if you have any problem with your stool incontinence or something, then, you know, like we can always refer you to a specialist, colorectal surgeon.
When you can come back to the hospital?
You can come back in 6 weeks, and we will have a follow-up for you to see like how the things are going on. But in the meanwhile, I'll refer you to the physiotherapist, and also keep on breastfeeding your baby for contraception. You know, I'll connect you to contraceptive clinic, have safe sex practices. And I'll give you this written information to read. And also, I can connect you to support group who have been through similar experiences. You know, you can share your experience with them, and maybe you feel better. And if you feel that, you know, you're not mentally feeling well, I can also connect you to our clinical psychologist and mental health counselors.
Okay. When I can do sex, doctor?
So sex is it is on individual basis. Usually when you're completely healed and when you feel you're ready, you can go for sex. And usually, you know, it takes 4 to 6 weeks. But if you're ready before that, if your wound
2
is
minutes
completely healed,
meaning?
if your wound is completely healed, then you can go ahead with it.
Okay. Thank you.
Thank you. Any questions for me?
Yes, you are dead well.
Okay, thank you.
But let me to review the domains with you one by one.
Yeah, sure.
Okay.
Sure.
So regarding with the communication with the patient, now this patient, you are in the hospital in the postnatal ward, and you are coming to the patient. Okay.
Yes.
So the approach different than when you are in the clinic and the patient came to you.
Okay.
Okay, so it is better to now the patient in the hospital. So first, hello, this is Hannah Clark. I am Dr. Maria. One is Dr. covering the clinic today. Can I confirm your age, please? This is better than as the case you are in the clinic and the patient came to you. In the clinic, yes, you can start. I can confirm your name and age, please. I'm Dr. Okay. So, but here, start by this is Hannah Clark because the patient in the hospital.
Okay.
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 So first, Next, after telling that and the incident and introduce yourself and what rapport with the patient, so the confirm of meeting understands that you had vaginal birth and during it you have had a tear, and I'm here to discuss with you. And then followed by, you must apologize.
Yes.
This is when the communication to the patient, apologize for what happened.
Yes.
Okay, I'm very sorry to that happening with you. I know that it is a difficult time for you. I'm immediately reassuring the patient that I will do investigations in the hospital to search about why this is happening with you, what we call incident report. And when the results are released, I will discuss with you the result and to know why this is happening with you.
Okay.
Incident report is very important to tell the patient from the start.
Okay.
Okay. Then very important to ask with every task, what is the expectation and the concern of the patient? You don't ask me what is the main concern. I will tell you voluntary, but I want from you to ask the role player after introduction and after situation awareness. I understand that you had vaginal birth and during it you had tears. So, and apologize, and then so you can tell me what is the main concern. What is the main expectation from this 2D meeting? So I will give you all the information. And after that, this happen again. Why is this happening with me?
Okay.
But by this information, the dialogue and the consultation around all of these points. So you know the main concern and the main expectation is very important. And then you are take much time for history. If you say we need a relevant history. Relevant history, very important about the recovery. Don't ask a broad question, what about your recovery as a role player? Now you are delivered, yes, everything is okay, you can go to the toilet easily, any problem with bowel work, any bleeding from down below, any discharge, you are breastfeeding your baby, you are named your baby, excellent name, lovely name, okay? It's very important as related to the communications. Then after that, target history, do you get pregnant before or no, and the mode of delivery. Target history about the obstetric history. Important to ask about the mode of delivery and the weight of the baby.
Yes.
Don't ask me about the weight of the baby. Is it breastfeed labor? In particular, if the baby weight is 4 kilograms, for example, so it is a breastfeeding factor for tear.
Yes.
Okay. This is regarding to the information gathering. It will take a lot of time. Yes, you ask about everything related to the information gathering, but you must concise and take less time in when taking your history. Okay. I think you don't ask me about medication allergy.
I did.
You ask me? Okay. Excellent. Excellent. Then explain why this happens, this patient. And you are explained well. Okay. So the management plan, this patient need to, when I asking you what I do to recover rapidly, this means that I want from you to discuss with me the management plan. Okay. And then you give you antibiotic, justify. Why giving me antibiotic? Because the wound is near to your back passage, so the risk of infection is high. So that's why we give you antibiotic for 7 to 10 days. And when mentioning antibiotic in patient breastfeeding, reassure the patient about this antibiotic is safe during breastfeeding.
Okay.
Okay. And then keep the wound clean and dry. Shower at least once a daily. Change your bed regularly. Pelvic floor muscle exercise. And I will appreciate you when you tell me the red flags. It's very important to ask the patient now discharged. Before the patient discharged, give the patient information, the red flags when the patient come back to the hospital is very important. If everything is okay, so give the routine another appointment after 6 to 12 weeks. You can come again to confirm that you do pelvic floor exercise regularly, to take the antibiotic regularly, and there is no problem related to your bowel opening. If everything is okay, and about 60 to 80% of these cases after 1 year they have no problem, and you can deliver vaginal delivery as an next pregnancy. But at this time, I'd say after 6 to 12 weeks, if there's any problem related to your bowel, at this time, we will refer you to specialist for what we're doing at the ultrasound scan of the back passage.
Yeah.
Okay? And then everything is okay after that. You are dead well. And also the incidence of recurrence, I think you told the incidence of recurrence around
Yes,
7
yes.
out of 100. And if the patient note any problem with hair bowel, so the next after elective cesarean section, it is preferable than vaginal delivery.
Yes.
Regarding the patient information leaflet, you are mentioned it late. So I want to remove from the start. After introduction, I will go to your concern soon, but if you are not mind, I want to ask you a couple of questions to know more about your condition, and then put plan for management after your agreement. And then at the end, I will give you patient information leaflet. If there is other appointment with the consultant, you can go, I will give you another appointment with the consultant. If the patient with GP letter, I will write back to the GP letter. This is from the start, you can collect marks.
Yes.
Regarding the communication. Why? Because maybe the time is limited and forget to mention patient information level. It's a safety point for the patient. Okay, so from the start, after introduction, before coming to your concern, tell the patient information leaflet, the contact number, consultant involvement, write back to your GP if there is the patient referred from the GP.
Okay.
So you are did well also. And I will appreciate your approach. Any questions so far in this station?
Yes. So domain-wise, how would you rate me in each domain based on my performance?
Yes, yes. Regarding to every domains, you are from by point you are passed, but in the communication with the patient, you don't try to reduce
Explore the concern.
Yes, regarding to the expectation to concern, you don't give me so give you borderline in the communication with the patient.
Okay.
But the applied knowledge and the information gathering, everything is okay. And also related to the patient safety, also I give you borderline because you don't give me what is the instance report and the documentation. It's very important instance report.
Okay.
In such case.
Thank you.
Okay.
Yeah, I'm asking
but
you.
Overall, you are dead well.
Okay, thank you. I'm asking you domain-wise, so like each domain, for each case, I go back and work on myself and incorporate those things. So that's why I'm asking domain-wise. And thanks for all your feedback. I really appreciate it.
Thanks. This is task 3, structured discussion.
Okay.
Ready? You have 1 minute.
Yes, I'm.
You can start.
Okay. Hi, I'm one of the exam candidate. I have read the case and I am ready for the discussion.
Hello.
Hi, how are you?
Okay, you can give me a summary about this case, please?
Yes, this case is Primi Gravida, who gave birth to 4.5 kg, assisted with forceps delivery, and she was given epidural. But when urinary catheter was inserted, she failed to pass urine after 6 hours.
Okay, so what additional information you need to know about this case?
So first of all, I would like to add more additional information for this patient. I would like to get an access to her notes. What was what were, if there were any risk at during antenatal period? What about the course of delivery? If she had any tear down below, if she has any excessive bleeding, she went into PPH or any other risk factor or any other problem. So I would like to get an access to her notes. That would be one of the thing. And then also if she was on epidural. So there's a few risk factor, 4.5 kg epidural, primary. These are the risk factor for having postpartum urinary retention. And then yes, with that that being said, I would also like to see that so then yeah, that would be the information gathering part, and I would like to assess the patient. I would like to do the examination of the patient. So if there is any episodemy, any third degree tear, I would like to get an access to her voiding record, labor progress and duration. And I would like to also know if she is in pain, because that could, I would like to give her pain relief and also
So give me what is your immediate action?
so immediate action is I would postpone her discharge basically, because she has this postpartum urinary retention. So I would postpone her discharge. I'll inform my consultant that what's going on, and then I will see for this patient that what's going on. I would like to put an indwelling catheter. If it's less than 500 urine, so that would be, I will use in and out catheter. But if it's
In
more
and
than
out
five,
or in the caster?
no, if it's less than 500,
Now the patient is unable to afford. So what would a type of caster be used now?
okay, so I would, that's what I'm trying to tell you, that if we measure the bladder volume with ultrasound, if it's less than 500 ml, I would try to use in and out catheter. If it's more than 500, I would use indwelling catheter for next 24 hours.
Yes. If more than 700, if more than 500 or 700?
500, I would use indwelling catheter for 24 hours and then reassess the patient. Reassess the patient
Yes,
during
if more than 500, what will you do?
I will place an indwelling catheter
For what?
for the urine drainage, and we'll keep it there for 24 hours.
24 hours.
Yes. And then I would like to see after 24 hours, I would reassess this patient and do the ultrasound if residual volume is more than 150 or less than 150. If it's less than 150, then, like we can, and if the patient is not symptomatic, then we can discharge the patient. But if it's more than 150, then we have to keep this indwelling catheter for the patient.
Yeah. So what is the risk factor for this postpartum voiding difficulty?
So there could be different risk factors. First risk factor, she was using epidural. That is one of the risk factor. Baby was big. There's possibility of perineal tears. There possibility of genital trauma. Then there is she was Primi Gravida as well. So these are some of the risk factor for this patient.
Okay, so some patients can avoid it, but high risk for retention. So how can you know what is the patient in high risk for retention?
Sorry, what are the possible? Can you rephrase your question?
Yes, there is predisposing factors for retention. You know what is the predisposing factors? Both the patient in high risk for retention.
Yeah, the predisposing factors, I just mentioned, like if she's taking epidural, and if the baby is big, if there is any genital trauma, any yes, these are some of the
Okay.
predisposing factors.
Okay. So what are the possible implications in the future?
So the possible implication for this patient is the patient can have long-term voiding difficulty, like for example, poor stream, dribbling, straining, recurrent UTI. If not managed well, the patient can have overflow incontinence, renal damage. So if there's a case, if the patient is not getting better, then we can involve our urologist as well.
Only
And
involve urologist or involve other members?
yes, it would be other members as well. If
Like,
she has like incontinence nurse, physiotherapist, and specialized nurse and midwife.
only?
Yes. And our consultant gynecologist, and mental health counselor, because if it can put her at she can feel depressed, so mental health counselor as well.
Do you want to add anything else? Till you have 2 minutes or 1.5 minutes.
And urology, urogynecology, and what else?
Okay.
Yes.
Okay.
That's it, I think.
Okay. Thank you. It is a very important task because it is a recall one,
Okay.
you know,
Yes.
and there is 2 articles since 6 months ago related to the post-void dysfunction overall, and there are flow chart. These are changed from the old talk articles before.
Yeah, I did that talk article, 500 ml, 150. Yeah.
You say?
That's a new one. Okay.
That is the new one. It's very important.
Okay. Okay.
Okay.
So I haven't revised this one.
Yes. So definitely after 6 hours, if the patient no void after 6 hours, so it is called postpartum urine retention. So what will you do? If the patient is unable to void or voided, if the patient is unable to void, so what is your first action? In and out catheter and residual assessment. If the amount is less than 150 ml, so we will search about other causes of retention like dehydration.
Okay.
Are you following me?
Yes. Yes.
Okay. If the amount is between 150 to 150, so proceed attempt at second void at 6 hours post-catheter removal. If between 250 to 700, not 500 like previously, okay? Between 250 and 700, insert catheter and retry after 24 hours without catheter. If more than 700 ml, so this patient, you can go to the home with catheter for at least 2 weeks.
Yes. Okay, it's 700 now.
Okay, yes. So if the patient void, but there are risks from the history, you are suggested this risk to the patient, what we call in the talk article, collected in VZ structures. So did you pass from the history, asking the patient, did you pass a good volume of urine? Did your bladder feel empty at the end? Do you have any sensations that you want to pass urine? What about the stream? It is normal. Any incontinence present or not? This question, by this question, you can classify this patient if this patient is high risk of retention or not. If this question suggests the retention, yes or no, even if the patient avoided. You understand me?
Yeah.
Even if the patient avoid, but there is risk, like patient don't pass good amount of volume, the patient not empty her bladder, the
Okay.
patient has the stream is abnormal, any form of incontinence. So at this time, you put in and out catheter to measure the residual access amount. If less than 250, proceed. Second, void after 6 hours removal of the catheter. Between 250 and 700, insert the catheter and retry after 24 hours without the catheter. More than 7, patient to go to the home with a catheter for more than or equal 2 weeks.
Okay.
If there is no
So-
history suggest retention, so second void at 6 hours, post catheter removal, in and out catheter, and measure the residual amount and follow all these passes.
Okay.
This is a very important talk article. And another point you are forgetting, it is very important point, the patient take epidural. So
Yes.
it is not important for you. What is the member must be involved in the care? The
And-
patient take epidural.
Anesthetist.
Yes, because you know that the epidural may be a risk factor for retention.
Yes.
So you must involve the anesthetist, in particular, if there is any risk related to the epidural. So, for
Okay.
example, the patient insert epidural and cannot move her legs after 4 hours from the epidural.
Yes.
So at this time, you can suspect that is an epidural hematoma. Being inserted the epidural in a patient platelet count less than 80. In patient in any form of coagulopathy. So we must
Yes.
rule out any anesthetic complications. If you are suggesting any anesthetic complications in terms of hematoma, at this time you can call other member, what is the spinal surgery team, to offering MRI scan to show any anesthetic complications with an urgent review by spinal surgery team, because if there
Okay.
is hematoma must be evacuated within 6 hours from the epidural. Otherwise, permanent paralysis can occur to this patient.
Okay.
Okay?
Okay.
If the MRI negative, so at this time request obstetric review. So it's very important multidisciplinary team, and also you involve the patient late. First, you also involve the patient. I will introduce myself to the patient. I involve the patient what has happened for her. Involve my consultant, the multidisciplinary team, including 1, 2, 3, 4, gynecologist, the urologist, anesthesia team. Very important to tell all of this. Okay,
Yes.
so this talk article and the flow chart is very important to read again.
Yeah.
And-
I haven't done this one.
Yeah.
When this TOG article, because I prepared it from the old TOG article, the
Yeah.
table. This is
So-
when this was. I haven't read this one.
Yes, I
When
will
this
send.
was
I
published?
will send to you the talk article. Okay.
Okay, when this was published?
What?
When this one was published?
Yes, this in 6 months is published, and
Okay,
I
6
will
months.
send it to you all the group of talk article at this time. Okay.
Okay, okay, sounds good. Yeah, because like I was in
It
that.
is an expected case in the exam. It's very
Oh
important.
yeah. Yes, yes, yes. Because like if we say about that 500 and that old TOG article, I think that information would not be enough now,
Yes.
because as
yes.
they already published this new thing.
And also add this arm again. If the patient avoid but is high risk,
Okay, okay.
how to assess and how to do.
So so this means that if she voided and has symptoms, still we have to do in and out catheter?
Yes, yes, if the patient is pass but not good volume, little amount of volume,
Okay, little.
urine,
Okay,
and also rule out any instance of dehydration.
okay, okay.
Okay.
Sounds good. Thank you.
Thank you. Dr. Mahmoud, you want to add anything? Dr. Mahmoud?
Thank you, Dr. Sarwat. You are doing very nice presentation and comment. Dr. Maria seems to have much knowledge, and this is very nice. But the main issue here, you are doing exam. You are not answering the knowledge only.
Yes.
So you put on your mind to be stepwise as OSCE exam. It's not part two exam. Uh, this is a general comment for your performance today.
Thank you.
Take care of communication. Take care of. I have one comment when the doctor asked to summarize the case. You are reading the question again.
Okay.
I collecting my comments and I will give you all together. Actually, this question came to answer as SPAR 2.
Yes,
You are
yes.
answering the question to the examiner by SPAR 2.
Okay.
You
Yeah.
understand me?
Yes. So
This means the examiner wanted to hear the word of SPAR tool. Any summary, how to
Okay.
give the summary, how to inform your consultant through SPAR tool, and then tell everything after that. The examiner,
Okay.
you want to hear this word.
Okay.
I will do summary.
mean,
I'll do it as bar tool. Okay.
Mm.
Yes, I'll use that word.
Mm.
Okay, but in general, I know you from your performance you studied very well, but you are
Okay.
taking care more for the knowledge only.
Sorry, I didn't get you. I'm taking more.
You are concentrating on knowledge.
Okay. So I
But-
have to concentrate on other domains as well.
Yes, that's what I want to say.
Okay. So now take the task 4, Dr. Maria.
Okay. Thank you, Dr. Mahmoud, for your feedback, and I would like to have more
I will
feedback from
come
you.
for my detailed feedback. I'm just leaving you with the Sharot is giving you much
Sure.
information. Really, I get benefit from this information. Me too.
Thank you.
Thank you. Thank you. I appreciate it. I want all the feedback. So, like in 1 week, I
I
have
will come
exams.
to you. Don't worry.
Yeah, so I can work on it and, go in the exam with more confidence.
You will pass, inshallah. Don't
Okay.
worry.
Thank you. Thank you. Next page, please.
Yes.
First page, please.
Time is over. You can start.
Okay. Okay. Hi, I am Dr. Iftikhar, one of the doctor in gynecology assessment unit. May I confirm your name and age, please?
Oliver Robert, 30 years.
Okay. And how are you doing, Olivia?
I'm depressed, doctor. I'm so afraid, doctor.
I'm so sorry to hear that, Olivia. I understand that you are 5 weeks pregnant and you have this vaginal discharge. Is that correct?
Yes, doctor. I'm so worried, doctor. I have the same symptoms, doctor, what I have in the previous topic, doctor.
Oh, I'm so sorry to hear that you've been through a lot. We are here to help you. Is it okay if I ask you some question and then we will discuss your management plan and I'll also address all your concerns. if that's okay with you. And I
Doctor,
also have your
doctor, please, I'm so
ultrasound.
worried, doctor. I'm so worried. I'm waiting for the ultrasound, this report, doctor. Please tell me what is the report, doctor, please.
Okay, so also I have your ultrasound report in here. So if you want, I can discuss the report with you before going ahead with the questions.
What?
I can discuss your ultrasound report before going ahead with the questions.
Yes, doctor, please tell me what is the result of report, doctor. I'm so worried.
Okay. Can you please move to the next page? Next page, please. So I confirm your name and NHS number. So I have first page, please. So I have this difficult news for you. Do you want to accompany someone?
My partner is busy, doctor. What happened, doctor? I feel that something not good happened with me.
I'm sorry of being bearer of this bad news. We also have a midwife if you want. She can accompany you.
No, doctor, you can tell me, doctor, please.
Okay, so is your report shows that you have pregnancy in the tube again this time in your left tube.
Oh my God, doctor. Another ectopic?
Yes.
Why
I'm
this
so
happen
sorry.
again for me, doctor? Why
I'm
this
so
happen?
sorry.
I have no children.
I am so sorry of being a bearer
Is the
of this
problem in
bad
my body,
news.
doctor?
No, it's not you. There could be certain reason. We are not sure at this point what could be the reason, but as you had previous
Doctor, I had
surgeries,
previous two ectopic, doctor, and the third one, and the last one is miscarriage. Why this happened with me? I have no children.
I'm so sorry, but here we have some options. I would like to give you some options, and we can discuss that in detail. But for that, I have to ask you some questions first. If you're fine, we can continue with this consult. But if you want to take more time and discuss it at the later time, that's also completely okay.
Okay, doctor.
Okay.
Give me my option.
Okay, I'm here to support you. Any specific concern you want to know about?
Yes, doctor, I want to know why this happened again with me, and how can we be pregnant or have a child after that?
Yes, we will discuss that shortly. I'm telling you all the options we can have. It's not like it's not the end of the road. You still have options. You still can get pregnant. So we will be discussing that option. But if it's okay, can I ask you some questions first?
Yes, yes, go ahead,
Okay.
doctor.
Okay. First page, please. Okay. So tell me more what happened in this pregnancy. Was it a spontaneous pregnancy or you tried any treatment?
Yes, this is spontaneous, doctor. Spontaneous pregnancy.
Okay. And all of a sudden you started this brown discharge, right?
Yeah,
Any other problems?
no,
Okay. And your previous two pregnancies were also ectopic, right? And surgery
yes,
was done. Okay. Any complication at the time of surgery or after surgeries?
no,
Okay. And I also want to confirm that you had a previous miscarriage as well, right?
yes,
Any
yes.
other pregnancies except that?
Yes, doctor, please tell me what is my option, doctor, please.
Okay. So so Olivia, I would like to tell you that you have some options here. You can still get pregnant, and that can be happen if you are with a partner. If you have
Yes, and now, doctor, you remove as other tube?
what?
We remove this tube also?
So yes, we have to remove this tube because that can pose a threat to your life if we don't remove it.
Any option other than removing the tube, doctor, you can do?
I'm so sorry to tell you that we don't have any option except removing the tube because already there was surgery was done on this tube, and after having surgery on the same tube, there
Not
is a
in this tube, doctor, this is the other tube.
Sorry?
And remove the right one. This is the left
Yeah,
one.
Yeah, this one, you also had surgery on this tube. They did a surgery called salpingotomy. You had ectopic pregnancy in this tube as well. They did it.
Mm.
And now you have pregnancy in this tube again. So we have to remove this pregnancy. We cannot keep it there because
So
there is
so we can remove the pregnancy and leave the tube, doctor.
that is not a possibility because we already did a surgery, and even if we try to remove the pregnancy, there is still increased risk of removing the tube.
So if removing the tube, how can I get pregnant again, doctor?
So we have some assisted reproductive techniques. We can do it, we can take your egg, fertilize it with your partner's sperm in the lab and put it back in your womb. We also have that option. It's not like the end of the road. And you can get pregnant with that, and we have more options as well. Yeah. So also, if I can ask you more questions, and then we will discuss more about this management, if that's okay.
So doctor, what will you do now with me?
So what we have to do with you is that we will, it would be a multidisciplinary team approach. Our consultant obstetrician would involve, our anesthesia team would involve, then also the specialized nurse, midwife, operating room staff would be involved. We will prepare you for surgery. We will, because we will take your
What
informed
is surgery,
consent.
doctor? Is keyhole surgery also? Or open
Yes, it's a
tongue?
key. Yes, it would be a keyhole surgery again. But if there is any complication during the surgery, it can always be converted to an open surgery. Keyhole surgery, usually it has quicker recovery and you can get better quickly. But before that, we have to rule out that you don't have any medical condition. Do you have any medical condition?
No,
Okay, any allergies, any medication you're taking for prolonged period?
no,
Do you drink or smoke?
no.
Do you know about your blood group?
Yes, doctor, O positive.
Any reservation for blood transfusion?
No,
Are you aware of height weight ratio?
no.
How's support at home?
Yeah,
Okay, and what do you do for a living?
I'm housewife.
That's nice. Any low moods for 4 or more weeks?
Yes, doctor. Since I suspect that I have ectopic, I'm depressed, doctor. I'm so worried.
Okay. Yeah, once your treatment is done, we will connect you to mental health counselor as well. So for this, as you have this pregnancy in the tube, one in the left side, we will try to do this keyhole surgery, and like we will make a small hole, and there is some risk associated, although we will remove that pregnancy, and but there is some risk associated with it. The risk include high injury to the major vessels, injury to the bladder, bowel, risk of transfusion, converting this procedure to open surgery. So these are some of the complications. But for that, we will give you a detailed information, and we will do your baseline investigation, get you reviewed by anesthetist, so that you're fit for the surgery, and then we will go with this keyhole surgery. Any questions for me at this point?
No, doctor.
And as I mentioned, that still there are fertility options. We can go with this IVF. I can connect you to fertility center after the procedure is done. And then also you can go for adoption. That is also a very good option if you want to think about it. And then surrogacy, if you don't want to carry your pregnancy by yourself.
Why adoption, doctor? Why adoption?
Time.
Okay. And I'll give you written information and patient. Yeah. Sorry.
Okay. Thank you, Dr. Maria.
Thank you.
Also, you are did well, but I wanted to tell you some important points.
Yeah, sure.
Your tone that is breaking a bad news, your tone, don't change it. And I noticed that the tone in the first task, like the second task, like this task. First of all, it is breaking a bad news, and you are faced with so irritable, worried patient. So your tone of voice must be a little bit slow,
Okay.
okay? To show sympathy and empathy with the patient.
Yes.
And when the patient tell you, I'm so worried, I am so irritable, I'm so anxious, so you tell, okay, so yes, I understand that you are, I understand, and your concern is valuable, and you are right, it's very difficult time for you. And I know that you have 2 previous ectopic and 1 previous miscarriage. Yes, you are in a very difficult time for you, and you are distressing. Yes, I know that. But I'm here to supporting you, and I tell you all the information needed to support your decision, and I'm helping you here. Okay, your tone, your voice must be slow, 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 and you are online exam. Yes, you are online
Yes.
exam.
Yes.
Okay, and also when you sit in the chair, you are leaning forward. When you're speaking with this patient,
Oh,
you can offer to her water and so on. Okay, so and when start, yeah, so because you wanted to ask me questions, in spite of I'm worried and I'm waiting for the result of the report, and I'm expert that I have 2 ectopic and have the symptoms. So I want to know what is the result now. Now. There is no time to ask me any questions. And if you review with me, what the domains you have?
yes.
What the domains?
Sorry?
What is the domains written?
Patient safety, applied knowledge, communication with colleague, and communication with patient. Okay.
There is no information gathering needed.
Oh, okay.
Even that, even if there is information gathering and the patient is so worried, so we can breaking the bad news first.
Yes.
Okay, so we can start your consultation after introducing yourself and show sympathy and empathy of the patient. I know that you are anxious. I know that you have 2 ectopic and you have another previous miscarriage. So, and the scan result in front of me, but I see that you are coming alone. If you want to call anyone of your friend or your partner and can postpone the consultation until he's coming. No, doctor, my partner is busy. So as you said, you can bring in one of my staff to attend the consultation because I give you a lot of information. Unfortunately, I have not good news for you. This is the first shocking word. And then after that, the scan showing that you have another ectopic in the left tube. And then silent about 10 seconds.
Okay, 10 seconds.
After giving this second news, the second shot, okay, you can
Yes.
wait about 10 seconds to absorb this news. And after 10 seconds, I'm very sorry to be a bearer of such news, Olivia. I understand that it is so difficult time for you and a stressing time for you. So if you're not mind, we can continue the consultation or postpone. You are dead. You are dead well, but I give you what is the best. Okay.
Yes, of course.
So
of course.
that is.
I know. I understand. I completely understand because I want a feedback. So if I'm doing good, I want to do best in exam.
Yes.
And with this feedback, I can do best.
Yes. So first, acknowledgement the patient. Yes, in the patient in distressing time, you are acknowledge this, and then prepare the patient to receive this shocking news by telling, unfortunately, I have not good news for you. First, second, the ultrasound scan show another ectopic in the left tube, very slow tone. And then wait about 10 seconds and can offer at this time water to the patient, leaning forward, and then take permission to continue.
Yes. So about this water and tissue situation, I wanted to do it.
There's not applicable online. Yes.
Yeah,
know.
so that's because they said like all
Yes,
these cases
yes,
are from
yes. But
telephonic
the
or
tone, but your tone, it is okay. It must
yeah,
your,
yeah,
must
I
your
understand.
tone. Anyone hearing your voice, you must feel that you are show sympathy and empathy with the patient.
Yes, yes,
Okay, so
yeah.
when the patient asking you, is there is problem with me, with my body? Why is this happen again? Why is this happen again? You are don't answering about this question.
Yeah, I wanted to answer, but I think I misunderstood with the information gathering. Otherwise, I would have
There is
told
no
her.
there is no need for
Yeah,
information gathering. This patient has previous two ectopics. So
yeah.
you know the incidence of ectopic in the general population.
Yes, recurrence is 1 in 10.
Incidence of general population one out of 90. In the general population, 1 out
Yeah,
of 90. This
yes.
risk is jumping to 7 out of 100 if the previous ectopic.
Okay,
Okay.
okay.
This when the patient come inform telling you this is any problem with my body. No, why do you think like this? Don't blame yourself because you have two previous ectopic. So the incidence in general population about 1 out of 90, but when the previous ectopic, the risk is jumped to 7 out of 100. Also, the risk is increased if there are IUD insertion, if using progesterone only pills, if you have any sexual chilling disease, and because also
Smoking. Yeah,
you are surgery, previous surgery in this tube. Okay,
yes,
this can you deal with this about this question? This is the answer about this question. Okay, then
yes.
the surgery. Yes, I appreciate that you have the only option is surgery. The only option of surgery after your consent, and you are mentioned the risk of surgery. Okay, but don't wait until the role player prompting you.
Okay,
Don't wait because this also decrease your mark.
okay,
So
okay.
so the management option for you, the suitable option for you, unfortunately, that's surgery. Surgery, you can do, it depends. When during the operation, it depends. We can do also salpingotomy again. We can do salpingotomy first because there is no other tube. So we'll try according to the situation during
Yes,
the operation. If I can remove all the pregnancy tissue and leave the tube intact, it's okay. Yes.
yes.
So first we'll try to remove the pregnancy tissue, trying to leave the tube. But if it is not possible, so at this time we can remove the tube.
Okay.
Usually this operation done through keyhole surgery, but also because you have two previous operation, so the keyhole surgery may be difficult, and we need to convert to laparoscopy through a slight incision, transverse incision above your bikini line. Am I kidding so far? Yes. So now I will admit you, inform my consultant, and will requesting for you for blood count. Okay, and then consent for I will apply the consent for this surgery. And also you know that there is no surgery without risk, and there is some risk because you have two previous operations before. Risk like this 1, 2, 3, 4. Am I clear so far? You must involve the patient repeated times during the consultation by the question, am I clear so far? Am I clear so far? And so
Okay.
on. Okay.
Thank you. And how will you rate me in each domain?
Yes.
How will you rate me in each domain?
Yes, and in each domain, so related to the communication with the patient, borderline because your tone it is not showing sympathy and empathy. Communicating with the colleagues, you are past. Applied knowledge, you are past. Patient safety, you are past.
Okay, thank you. Thank you.
Okay.
I'll work on I'll work on communications.
Okay.
Yeah.
But
Thank you.
overall, as Dr. Mahmoud, I will appreciate your performance, and
Thank you.
inshallah, you will pass this exam.
Thank you. Thank you. I'm just trying my best. Let's see.
Okay.
And
You
I
have-
was just, I also wanted to let you know that I just moved my head because like I was unable to hear. I didn't realize that I'm wearing headphones. So I was like, okay, maybe I can hear through the speaker. So that's why I moved like this.
No problem. Okay. So the task 5, also you have 2 minutes and there is 2 slides.
2 slides. Okay.
Yeah. It's clear, is clear. Screen is clear.
Yes, kind of clear. Okay, next page, please.
Okay.
This one I cannot see clearly. Okay, I'll try to see it. Okay.
Zero dynamic style.
Yes.
Not clear?
Yeah, I can see it. Initially it was not clear, but now it's clear. First page, please.
Time.
Right. Can I start?
Hi, I'm Dr. Iftikhar, one of the doctor in clinic today. May I confirm your name and age, please?
I'm Alison Smith, 55.
Okay. And how would you like to be addressed?
Alison is fine.
Okay. How are you doing, Allison?
Fine, doctor.
Okay. So Allison, I got this. I know you have been referred by your GP stating that you have urinary incontinence while coughing and exercise, and you have also tried pelvic floor muscle exercise, which is not relieving your symptoms. Is that correct?
Yes, doctor. Yeah.
Okay, let me tell you briefly what we will be doing in this consult. I'll be asking you some questions and then we will do your management, discuss your management plan. If you have any concerns, you can interrupt me anytime.
Okay.
So Alison, tell me more what's going on with your waterworks.
Well, doctor, since few months ago, I realized that when on exercise, when coughing or sneeze, I leak suddenly. So I go to my GP, which
Okay.
tell me to do some exercises, but I think it is not working well. And also requesting for me test in front of you, doctor.
Okay. And can you tell me more, like, do you just leak with coughing or exercise, or you have also accidents like before reaching to the restroom, you have sudden urge to pee?
Only when I'm coughing or sneezing or do my work in the house, doctor, my home.
Okay. And any dribbling of urine post-void, like
No,
after passing urine?
no.
Okay. Okay. Any increased frequency of urination during the day?
Not more, doctor, but the problem, as I said, when my coughing just leak.
Okay. Okay. And any burning micturition, burning sensation while you having urine?
No,
Okay. And also any blood in your urine?
no.
Okay. Some personal question. Are you sexually active?
Yeah.
Any incontinence while having sex? Incontinence of
I don't notice this.
Okay, okay. And what about any problem with the bowels?
My bowel, no.
Okay. And you just mentioned that it's with basically coughing, exercise, or something like that. Is that
Yeah,
correct?
yeah.
Okay, okay. And anything else you would like to add with relation to your urine incontinence?
No, doctor, I want solution for this problem because it's affecting my life.
Oh, okay. I'm so sorry to hear that it's affecting your quality of life, but we are here to help you. So what about have you ever got pregnant?
Yes,
So what was the mode of delivery and like
vaginal
what happened?
delivery, doctor. I have two children.
Okay, two childs.
Yeah.
Okay. It was a normal vaginal delivery?
Yeah,
Okay. Okay. And are you up to date with your smears?
yes,
Okay. When was your last menstrual period?
since 1 year.
1 year. Okay. So, okay. Any dryness down below
At the moment, no,
as a moment? No. Okay. And any medical condition like chronic cough or any other condition?
no,
Okay. And so also any surgeries on tumor down below?
no,
Okay. And any allergies, any medication for a prolonged period?
no,
Okay. And also, what about do you drink or smoke?
no, no,
Any recreational drugs?
no.
Who do you live with?
I'm a teacher.
Uh, your teacher?
I'm teacher in the school.
No, I mean, who do you live with?
Yes, was my husband.
Okay, and you're a school teacher. That's great. That's
Yeah,
nice.
yeah.
Okay. I know you mentioned that this problem is impacting your quality of life, but is it also affecting you mentally, like any anxiety, any depression for 4 or more weeks?
No,
Okay. Okay. Thanks for giving me all the information. Anything else you would like to add?
no, doctor.
Okay, thank you. Next page, please. So, Allison, I confirm your name and age. Allison Smith, 55 years old, and this test was done on the 28th February. And I would like to confirm that this test shows, based on your results and your your history and the test result shows that you have mixed incontinence and the more predominant let me tell you what this means because it has more predominant stress urinary incontinence. So stress urinary
What does that
incontinence,
mean, doctor?
yeah, that's what I'm going to tell you. So what does it actually means that when there is increased abdominal pressure, you start leaking urine, and the strength of the neck of the bladder is actually weak. It's not its strength is weak, so that's why it's happening. So for that we have to do different procedures, although you have tried pelvic floor muscle exercise and um, uh,
I will
uh,
do pelvic floor exercise, doctor.
what.
I will do pelvic floor exercise
Yes, you mentioned that. Can I go to the first bit? I know you have did it. For how long you did it?
for 2 months.
Oh, 2 months. Okay. So actually, that's actually very good that you tried, but it did not improve your symptoms. May I know your height weight ratio if you don't mind me asking?
I'm not sure.
Okay, okay, no problem. That's not an issue because first line, if we tried with lifestyle modification, reducing some weight, if your height weight ratio is on the higher side, that could also help. And but you already tried this pelvic floor muscle exercises and it's not working. So now we have different options in here. We have surgical options and medical option. The recommended option, like which improve your symptom, is surgical options. So what do you think about both options,
So,
Alison?
doctor, the same result with both options for me?
No. So a surgical option has a lot better
So
result.
tell me the options of surgical, doctor.
Okay, so Alison, we have a few procedures here. The
Time
first one
off.
we
Time off.
time over.
Yes.
Okay.
You know why?
Oh, I didn't realize it that
You
time.
are take 7 minutes in information gathering in the history. 7 minutes.
7 minutes. Oh wow. I didn't realize it.
Try
I
to
didn't.
concentrate about this point, please. If you say obtain focused relevant history.
Yes, yes, yes.
A relevant history starting by analysis of the present complaint. If you missed any after that any point, there's no problem. Okay, so you don't lose much time. Train yourself. Take 4 to 5 minutes only in the history by the clock.
Yes, yes, yes.
4
I
to
didn't
5.
realize I was not looking at the time at all.
So the seven, if you are taking more than 5 minutes in the information gathering, sure you cannot complete the task.
Yes, yes, that's true. That's true.
In particular, the stress of the exam.
Yes.
Try to train yourself, please, 4 to 5 minutes maximum. You have to obtain relevant history. Relevant history means you are focusing histories. This means that you must rule out the risk factors. Now, this patient, the option, the recommended option, as you said, surgery. So you must ask the questions to rule out more increased risk of surgery, like this patient, if have any surgery before, because the risk of colon suspension. Yes, it is very important question. Medical history, important because this patient undergo surgery. Menstrual history is very important because you must ask about when's the last menstrual period.
Yeah,
You have in any hormonal replacement therapy at the moment, so you must be stopped before surgery. And it is then safety measures. Okay. Yes. Then the mode of delivery and the parity is very important for the risk also of colon suspension. Okay. In addition to that, the relevant questions, as you said, since when you start this leak, do you still with yourself? Do you rush to the toilet? Is affecting your life in any way? Okay. Very important questions you don't ask me related to the pelvic floor exercise. This patient starting pelvic floor exercise, you must ask me, it is supervised or not?
Okay. Okay.
I appreciate that when you are asking me for how long. It's very important.
Yes.
And I tell you 2 months. And again, you can answer this is not enough to give this effective
12 weeks.
pelvic floor for 3 months.
Yes.
Pelvic floor must be supervised. This means that done under supervision, physiotherapist, and then for 3 months.
Yes.
Okay?
Yes.
Okay. So again, very important for the communication. So if you start read the scenario with me, please.
Sorry?
Read the scenario again.
Yeah, so it's ST5 covering the gynecology clinic. Lady, you're about to see Mrs. Allison, 55 years old, referred by GP, urinary incontinence, coughing exercise. And she had pelvic floor muscle training, which she did not improve. Filling and voiding cystometry was done. Attached is her result, and her consultant saw her, Dr. Rose, who is on family leave for family emergency. So I think in the beginning, I should say that my consultant is not here. Is it okay to continue the consult?
So it's very fatal mistake. This is fatal mistake.
Yes.
So the examiner don't hear anything because maybe as a role player, you don't need to discuss with you from the start.
Yes.
So first you must read. You must read. The 2 minutes is very important because these 2 minutes give you the performance, good performance if you use the 2 minutes well.
Yes. Yes.
During the 2 minutes, you must read the domains, you must
Yes.
read the scenario, and what you need, what must be till. You need
Yes.
focus history, so focus history. There is
Yes.
no information gathering, so there is no information gathering. What's the domains? And usually answer the concern of the role player. So
Yes.
very important first, you must apologize. Introduce yourself. Apologize on behalf of my consultant. I am Dr. Maria in the gynae clinic today. I'm here today on behalf of my consultant because my consultant in sick leave, whatever. So if I'm not mind to continue this consultation with you, yes. Definitely the role player telling you yes during the exam. But you
Yes.
must tell that. Okay?
Yes.
So what is
Yes.
main expectation and the concern? Also, I will go to your concern. So you must fix introduction. I will go to your concern, but if you're not mind, I want to ask you a couple of questions to know more about your condition, maybe run some investigations, book plan for management. I will give you another appointment with my consultant. Very important here, because this patient come to meet the consultant. So you must give another appointment with the consultant and write back to your GP. All of these communications very important, and you can collect mark from nothing. From nothing.
Yes.
Maybe
Yes.
you don't know anything about the case at all, but still you can pass.
Yes.
And these stations usually with layman examiner. You say layman examiner
Mm-hmm. Yes.
have big score,
Yes.
and you must complete the task about the surgery. Discuss with me about the surgery, colbo suspension, how to tell the patient about colbo suspension.
So this is a procedure in which it can be done through keyhole surgery or open surgery. So what we have to do, like we will tighten your muscle of the neck of the womb and put it back in its normal position. But with this surgery, you will relieve the symptoms, but there's also possibility of recurrence, and 10 to 15% also have the risk of overactive bladder, which
What
means
is the
that you
success
might.
rate? What is the success rate?
So success rate is almost 85 to 90%.
Success rate out out of 10. 8 out of 10.
8
Success
out of.
rate of colbo suspension. Yes,
Okay.
after consenting and informing you what is the risk and so on. Okay.
Yeah, and that would be one of the procedure, and then we have another procedure called it
So
rectal fascial sling.
if this patient 44 years old, so we can offer her colbo suspension.
Depends on fertility wishes.
Yes, yes, excellent, excellent.
Yes,
Okay, is
depend on her
any other
fertility.
options than colbo suspension?
Yes, facial rectal sling. That is, we take an tissue from other part of body and try to put it around the neck of the bladder to strengthen it. And then this procedure, and then we have another procedure we called mesh surgeries. For that, there's complication with the mesh. But if you are willing to do that, we will give you more details about that procedure. And also, last not but the least, we have bulking agents.
Excellent.
Yeah. And
Excellent.
if you refuse all these procedures, then we have another medication, we call it duloxetine. We can give, or based on your medical history, we can give you that medication.
Medication.
And
So yes. At this point, regarding to the stress urinary incontinence, first of all, you can discuss only about surgery.
yeah, okay.
Don't give the other option except the patient refuse surgery or unfit for surgery.
Okay. Yes.
Why? Because you first you tell me there are two options: surgery and medication. So I will asking what is the best for me. In stress urinary incontinence, the option first surgery. If the
Yes.
patient is unfit or refusing the surgery from the start, you can tell there is another option, this medication, what called duloxetine, and so, and give the side effect duloxetine. But the recommended option is surgery.
And also for it would be a multidisciplinary team approach, the supervised
And also
pelvic
some important question in the history also don't ask me about is any bulge from down below. Very important to rule
Yes.
out prolapse.
Yes, yes. Also,
Okay.
that's a very important question. And also silicone barrier creams, incontinence pads, and patient formation leaflet connected to support groups,
Yes,
all that.
yes. Patient information, as I said, till from the start.
Okay.
Before
Okay.
going to concern, train yourself about this. Patient information leaflet, another appointment with my consultant, write back to your GP from the start.
Okay. Okay.
Okay?
Sounds good. Thank you.
Okay. Thank you.
So
Mahmoud?
also with the previous one,
Yeah.
the urinary incontinence. So no, the urodynamics.
Yeah.
So urodynamics. There was increased detrusor pressure as well in here.
The trouser pressure is not more than 15.
Oh, okay, okay.
Okay,
Because I
so
was seeing the next.
increase intra-abdominal and increase intravesical pressure.
Okay, okay.
Okay.
Yeah, and what about the next like the second? No, here. This second part of the
Yes,
urodynamics.
this is avoiding.
Yes.
This is
Yes.
avoiding. This definitely increased. No problem.
Yes.
But
Okay.
you are commenting on the filling phase.
Okay. Okay.
Okay.
Sounds good. Okay. Thank you.
Okay. So now with the task number 6 with Dr. Mahmoud. Also, you have 2 minutes. Dr. Mahmoud?
Okay.
Yes.
Yes.
Dr. Maria, ready?
Yes, yes, I'm ready.
Okay.
And just
So
I need to drink.
let's start. This is your task. You have 2 minutes to read. Then we'll start.
Start, Dr. Maria.
Yes. I'm one of the exam. Good afternoon. I'm one of the exam candidate. I have read the case and I am ready for the discussion.
Hello, doctor. Give me a summary about this image and what is the diagnosis.
And what is the diagnosis? Okay, actually we were performing a laparoscopic surgery, and I had 2 assistants, ST1, ST2, and ST2 actually mistakenly used trocar instead of manipulator. And based on the picture, what I can see is there's a uterine perforation.
Okay, so what's your differential diagnosis?
So the differential diagnosis include uterine uterine perforation. There could be perforation of bladder there, and there could be injury to the vessels.
What do you think? What is the reason for this mistake?
The reason for this mistake could be that the ST2 was maybe not paying enough attention, and are also maybe not trained enough to be assisted, and also there could be lack of knowledge for the ST2, and for that after the management I would like to advise her to go for reflective practice as well.
Okay, so what's your immediate action now?
So immediate action would be that I would like to pause the surgery. I would like to inform my consultant. I would also like to inform my operating
How
team.
you will inform your consultant?
So first of all, I will inform my operating team and anesthesia, and then coordinator nurse will inform the consultant.
How you will inform the consultant? Now the coordinating nurse giving you the phone to inform your consultant.
So,
Tell me as you are telling your consultant.
So the consultant, I would like to tell my consultant that we have this case. Why we did the laparoscopic sterilization. I had two of my assistant, and we had this unforeseen situation right now. And this is uterine perforation, and we want you to be here for further help.
Okay, so continue your action, your management.
Okay, so after pausing the surgery and informing my team and a status consultant, I would so for this patient I would like to go with resuscitation, assessment, investigation, and management side by side. And as this is a uterine perforation, I will inform the team that it's a uterine perforation, and so also I have to calm down my ST2. Maybe that the person or ST2 is terrified. So what we have to do is we have to look for check for the vitals, that how the vitals of this patient are, and then also we have to do the catheterize the patient. Also, we have to take see if the nurse has drawn the blood for cross match, and also we will ask the trainee not to do any further manipulation. And then my ongoing management would be that I have to check that if the patient is hemodynamically stable or not.
What about the talker? You will remove?
Once my consultant join us, then I will remove it after checking the patient is stabilized, and then we will remove. Otherwise, we won't. We have to see the hemodynamic stability and ensure that everything is in place. Then we will remove it.
Okay. Can you tell me how you will deal with the ST2 and the patient?
Yes, so after remove, we have to assess that if it's more than 0.5 or less than 0.5, and we will manage this accordingly. And then once we are done with this procedure, then we will complete the laparoscopic sterilization. But once everything is done, so we have to follow the clinical governance issue with the patient. That would be that we have to inform the patient. Duty of control, we have to be upfront to the patient that what actually happened and why it happened, and we are here to support the patient and what we did during the procedure. And we will also tell the patient that we will fill out a DAREX form that is like this should never happen, and then we will involve our risk management team as well, and thorough departmental meeting would be done, and also we will keep the patient informed and posted what's going on, and post-operative care, postnatal notes, everything would be given to patient, antibiotic, painkillers, and what happened happen during the surgery. And then GP would also be in the loop that in the future communication, the patient for the future communication. And if it's repaired, if it's more than 0.5, the next surgery, if she has to undergo the next delivery or a cesarean section, it would be a classical cesarean section. And also, if the patient is not still satisfied, we can connect her to the pulse. That is on the patient side. But if also we will go with the enhanced recovery program up and about, early mobilization, DVT, risk assessment, and with the trainee, because the trainee could be terrified and that can impact his workability. So we can arrange a session for his reflective practice, what went wrong, how he can improve on it. We can have a teaching session with him, and also skill and drill workshops for the trainee that will boost his confidence as well. And at the same time, he will learn from his mistakes. And we have to ensure that it's one incident, although whatever happened should never happen to the patient, but it shouldn't impact your work and mental health as well, because these things can happen in clinical practice, and we should know how to manage them effectively and how to do a reflective practice and not to do it in the future.
Anything else you want to add post-operatively in the management of the patient?
The management of the patient is, I mentioned that perforation, we will surgically repair it. And so also the trainee can have reflective practice with the supervisor, and GP would be involved. And the patient would be involved about all the things. That's it.
Okay. Anything else you want to add in general for this question?
No,
Still
I
you
think
have 2 minutes. Still you have 2 minutes.
yeah, I think skill and drill workshop for the trainees will prevent these incidences. And so that's why we will have more skill and drills and teaching sessions for trainees to avoid this situation, this complication.
Okay. Thank you, Dr. Maria.
Thank you.
Very well done regarding this case. You covered most of the important points, really.
Thank you.
You have good situation awareness, but still some missing points is very important.
Yes.
Let's go one by one.
Sure.
Regarding this case mainly came for safety, patient safety, and for communication with colleagues. Okay, communication with the patient.
Yes.
Okay, so regarding the first question, what's your diagnosis? How to give you go direct for the diagnosis. My diagnosis is uterine perforation. So the next question was your differential diagnosis. The differential diagnosis, there may be accompanied injuries. You mentioned bladder injury, yes?
Yes, I did.
What about ureteric injury? What about bowel injury?
Yes, that could also happen.
It could be accompanied, yes?
Yes.
Okay. So if you have differential diagnosis of bladder injury and bowel injury, so where is the MDT? You will manage bladder injury alone? You will manage bowel injury alone?
No, it would be MDT
So
approach.
this is important missed point in the situation awareness and the patient safety and your communication with colleague. You imagine 1 point, you lose 1 mark in each domain.
Mm-hmm.
And so you, at the end, you will find yourself, you know everything about the case, you know the diagnosis, you know the management, you know how to deal, you know the duty of condor, you know you mentioned the documentation, you did everything, but you lost mark in each domain for only 1 point. Okay, so this is the situation awareness is very, very important, all the situation. But you mentioned I will contact anesthesia, operative team, I will prepare. What about blood bank if this patient bleeds more?
Yes, blood bank. Because I said the nurse will take a cross match and arrange the blood. So
I will
yeah,
tell
the blood.
you I will tell
Yeah.
you what do you think. You think now the patient is there is perforation and the patient is stable,
Yes.
and this is actually not mentioned. This is your imagination only.
Yes.
Maybe this patient at this moment not stable.
Yes.
So if not stable, your action will be different.
Yes.
Understand? So
Yes.
if this patient unstable, you may proceed to strict. So this is a different scenario.
Yes.
You should mention this. If the patient is stable, I will go for this. If the patient is unstable, I will go for this.
Yes. Yes.
Okay? So this is now you are aware about everything and every option. And
Yes.
actually the examiner giving you guide. What you will do, what is the immediate action? Immediate action, you said, I will stop the procedure and then I will check the injuries. I will check the vital signs of the patient. The patient has bleeding, she's vital stable or no. There is a associated injuries or no. And according to my diagnosis, my accurate diagnosis, I will take my actions. But you deal with the task as this patient only tried perforation and the patient is stable, which actually is not mentioned.
Okay.
You understand me?
Yes.
Okay. This is regarding all over the situation aware. Regarding the SPAR tool, how you are telling the consultant, I asked you question, how you will tell your consultant. I will tell my consultant, according to SPAR tool, he need to hear this item. Show the examiner that you know.
Okay.
You understand me?
Yes.
He want to listen to some important words. Give him the words and take them off.
Yes.
I want to listen to duty of control. I want to, if you didn't say anything else, I will give you the mark.
Okay.
He want to listen to documentation.
Yes.
Documentation, the briefing, duty of control, SPAR tool, blood bank, technician, anesthesia, general surgeon, urologist. You understand me? He's waiting some words. Give him the words to get the
Okay.
mark.
Okay. And one question, Dr. Mahmood. As this is a uterine perforation, although my differential could be the ureteric injury, bladder, bowel, whatever. So at that point, we should say that it would be multidisciplinary team approach based on the
finding.
based on the finding. Okay. It
Yes.
would be a multidisciplinary approach based on the finding, and I'll involve the specialists. I think
Yes,
that
you
would
should
be the
go
approach.
through this approach. It will be multidisciplinary according to the finding. I will include the urologist if there's ureteric or bladder injury. At
Okay.
the end, he will tell you, no, it's only uterine perforation and the patient is stable. So
Okay.
you can go this way.
And if it's after saying, because I said that I'll check the vitals, but I should say that I will see if the patient is hemodynamically stable or unstable. If the stable, I'll do this. And if the patient is unstable, I would like to go with the transfusion, fluids and all that stuff, right?
Yes, this is the approach. If the examiner want to summarize the answer, he will tell you the patient is stable. So you will
Okay.
go only in this way.
Okay. Okay.
Or he will answer you, the patient is unstable now and she about to collapse. So he wants other way.
Okay.
Or he will leave you to give the two items.
Okay. What if he says the patient is unstable and about to collapse? So how should I approach it? As you are an examiner, so what are your expectations from the candidate in that particular situation?
I'm waiting your answer.
Okay.
Imagine this patient is unstable and about to collapse. As a situation awareness, what's your action in ordinary life?
Yeah, so like arrange so we already arranged the blood. We will also involve
No,
the
I
blood.
want to listen only to one word. Give me the word.
We would like to resuscitate the patient first.
No, give me the word. You are alone.
Call for help.
Call for help. Okay, call for
You
help.
need help.
Okay,
You need
call
your
for-
consultant. Don't miss your consultant.
Okay, yeah, consultant. If the
Yes.
patient, even if the patient is stable or not stable, I'm involving him. So
No.
yes, okay,
If I'm telling you the patient is about to collapse,
okay,
you will not manage alone. Tell
yes,
me, I will call my consultant. I need to listen to this word and he will give you in the safety point boss.
Oh, okay, okay,
Then you can continue. Everyone will tell, I will prepare blood, I will give, I will resuscitate. But who will miss the consultant will not miss.
okay, okay.
You understand me?
Yes, yes.
Okay, this is approach how to deal with the station to bus.
Yes,
I
yes.
know you can manage this patient, but in
Yeah.
the exam, they want to take some items to give you the mark.
Okay, sounds good.
Okay.
Yeah.
Uh, so this is regarding MDT. You missed the general surgeon, urologist, blood bank. Okay. Regarding the safety, there is some points I told you regarding the communication with the patient, communication with your ST2. Very nice. I will pass regarding this point. Okay. So overall, you did well in this task, but to take care of these points I told you about.
Okay, so with patient safety, will you pass me, fail me, borderline?
Okay, you know about I know that you have this exam before. Yes.
Yes, yes.
Okay, you know there's some points as I told you. If you miss the consultant, you will not pass.
Okay.
Whatever you tell.
Yes.
This is how they are giving you marks.
Yes. Okay.
You find you are doing very well, but you didn't pass exam
Okay.
because of these small tricks.
Okay.
Okay.
Okay. Okay. Thank
Let's
you.
go for next. You have 2 minutes. Start.
Is there any other page?
No other page.
You can start. Time over.
Okay. Good afternoon. I am one of the exam candidate. I have read the case and I am ready for the discussion.
Doctor, this is a simulated patient task.
Or
Take
simulated.
care.
Okay, simulated. Okay. Hi, I'm Dr. Iftikhar, one of the doctor in clinic today. May I confirm your name and age, please?
Hello, doctor. I'm Sally Jones. I'm 35 years old.
Okay. And how would you like to be addressed, Sally?
Sally, doctor.
Okay. Sally, how are you doing?
I'm feeling unwell, doctor.
Okay. Sally, we are here to help you. I'll be asking you some questions, then we will discuss your management plan. If you have any concerns, you can interrupt me anytime.
Okay, doctor, please, doctor. Doctor, I need to vomit.
Okay. I'm so sorry, Sally, that you've been going through this tough
Doctor, I
situation.
need to vomit.
Okay. I can give you this bag and also I can give you some
Doctor,
yeah, I can give you this bag. You can use this bag for the vomiting. And I would also like to give you some medication for your vomiting and your pain, if that's okay with you.
no, doctor, I'm okay.
Okay, okay. So is it okay if we continue with the consult?
Okay, doctor.
Yes. And I understand that you're not feeling well, but If you want, like I can give you all the medication, and also we would like to pass IV line and take some of the samples before we start with the consult. And in the meanwhile, I'll do the resuscitation, your examination, investigation, and management side by side. So everything will go side by side, if that's okay.
I want to know what's my problem, doctor.
Sally, if it's okay, I would like to ask you some question, and we have to do some investigations as well. So that's how we will be able to know that what's going on with you.
Okay, doctor, but I want to know what's my problem.
Yes. But in order to I have to ask you some question, and then we will do your investigation. Then I'll be able to make your diagnosis that what problem you have.
Okay, doctor, sure.
Okay. Sally, tell me more like what happened to you before surgery and after surgery, why the surgery was done.
Doctor, actually, I'm searching to have a baby. They told me I have to do keyhole surgery to know
Okay.
what's my problem.
Okay.
I just finished my surgery. First day it was okay. Second, third day I was start to feel some nausea, but today I cannot tolerate. I wanted too much times. I'm taking painkillers, but it doesn't work.
I'm so sorry to hear that you've been through such a difficult and tough situation. We are here to help you, and we will support your decision, and whatever I can, I will do it for you. You mentioned, like I can see that you have vomiting, fever, and pain. Can you tell me more about your pain, like, and your situation as well?
I have pain in my tummy, and this is in the right side of my tummy, and
Okay.
and too much vomiting today. Doctor, again, I want to vomit. Doctor.
Okay. I'll give you. Is it
I
okay if I
want
give?
again I want to vomit now.
Is it okay if I give you this vomiting bag and I'll start you on medication? I think that would be a
Again,
better option.
doctor, please.
I think I'll give you this vomiting bag and I'll start you on vomiting medication. And I will also start some fluids for you. You will feel better. And also, yes, I'll start you on fluids as well. Is it okay? Hello?
I'm
Yes.
feeling unwell, doctor.
Okay, so you know what, Sally, I'll give you this hydration and this vomiting medication, and then also we would like to run some of your tests, if that's okay with you. I'll give you all these
Okay.
fluids as well.
Okay,
Yes. Okay, and okay, are you feeling comfortable now?
Okay, doctor.
Okay, is it okay if we continue with this consult?
Continue.
Okay, okay. And so tell me, okay, any previous surgery other than this one?
No, doctor.
Okay, any other, when was your last menstrual cycle?
It was about 2 weeks ago.
2 weeks ago. Okay, and what about your any medical condition for which you see the GP?
I received painkiller from OTC, doctor.
Okay, no like clots in lungs and legs, any hypertension, diabetes, nothing, right?
No, doctor.
Okay. And what about any allergies to any medication, or are you taking any medication except this ibuprofen?
No.
Okay. And any reservation for blood transfusion?
No.
What's your blood group?
A positive.
Okay. And do you drink or smoke?
Occasionally.
Okay. Any recreational drugs?
No.
Okay. And what about your how's your support at home?
I'm living with my husband.
Okay.
Everything is fine.
Thank you. Anything else? Any low modes for 4 more weeks?
Sorry, doctor, cannot get it.
Any low modes for 4 more weeks?
Yes, doctor. I want to know about my case. I'm
Okay,
feeling
okay,
anxious.
so Sally, what we will be doing that we will be running some tests. We will do your I'll do your examination in the presence of chaperone to see like if there is any masses. Also check. I'll pass the catheter to see if there's any urine output, and then also we will send some of the investigation, including your full blood count, and then urinalysis as well. A full blood count to rule out any infection. Full blood count rule out an infection, and urinary analysis to rule out urinary tract infection. I will also examine your legs for any swellings, and then also specifically for this condition, it looks like that you have a condition called ureteric injury based on the but for that, in order to make confirmed diagnosis, we would like to do some specialized tests. We call it CT urogram or IVU or ultrasound as well.
Why, doctor? Why? What are you suspecting?
So there could be possibility like of having ureteric injury, but we are not sure at this point. So that's why, and we will be
This is
monitoring.
dangerous.
Yes, if that's the condition, we have to treat you for that. You know, we might have to do the surgery for that, but it would be a multidisciplinary team approach. Our consultant would be involved, urologist, urogynecologist would be involved, specialized nurse, midwife, anesthesia would be involved. But only we will do that if that after doing all these specialized tests, if it's confirmed, then we will go with that.
Okay, doctor. I will be fine after that.
Yes, we have to do a surgical repair if that's the case, and then, but there could be other possibilities. There could be possibility that, you know, you didn't get enough fluids. Maybe there is a vessel injury. These are also the possibilities. But it more looks like that your ureter, that is the tube that is connected with your bladder, your water pipe is water bag that is connected to the water bag. So that is most probably the problem, it looks like.
What about my tubes?
Tubes, I would like to get an access to your operative notes, and then I'll be able to tell you. I think the surgery was done, but I'll give you a definitive answer about after checking your notes. How about that?
How I can test my tubes?
Yeah, it was a very difficult surgery. It was a very difficult surgery, and there was a lot of adhesion around the tube. So that's why there is possibility of these complications.
So I can get baby again, doctor, or no?
Time over.
Yes, okay.
Thank you, Dr. Maria.
Thank you.
This is actually one of the most difficult role play you will face. Role play
Okay.
want to distract you to many ways.
Yes.
Okay, you have to be calm and steady. This is the only
Yeah.
way you can overcome this stage.
Yes.
Okay, actually, this patient we can take each domain separately.
Yes.
You are now talking to unwell patient. She's feeling sick.
Yes.
And she is telling you, I'm feeling unwell. And you said, okay. Does it make sense?
No. That's why I was confused here, because I was giving her vomiting bag and wanted to give her fluids.
This is another issue. But if the patient telling you, I'm feeling unwell, I'm feeling depressed, I'm feeling in very bad mood, I'm feeling, don't tell okay. What's the meaning of okay? I'm accepting. Tell her I'm sorry. I'm sorry
Yes.
for the be on the same mood of the patient. Accept angry patient. Be of the same mood of the patient. You said you should be sad.
Yes. What should I say?
Okay. If the patient is sad, if the patient unwell, you should show your sympathy.
Yeah.
Understand me? The second thing, if the patient is vomiting now, don't talk to the patient. The patient is vomiting and you are continuing your talks.
Okay. So
Don't
what
tell
should
her, I will give you bag, I will give you tissue, I will give you... Wait. Then you can offer in brief. You need some medication. After she finish, are you fine now? She is vomiting, and I'm telling her, I will give you back, I will give you medication, I will give you fluid, I will call my sister, I will call the. You understand me?
Yes.
If she is doing something, if she cried, if she shout, if she vomits, you should wait.
Yes.
Only give one word. You need tissue, you need water, finish. You understand? This is done in the real life, but in the exam, under stress, you will do anything.
Yeah.
If
So
you saw someone vomits, you will talk to him.
No, so that's why I'm confused here, because I kept on offering. I said, like, I'm sorry you've going through this difficult situation and all that stuff, and then I was offering her. I didn't realize what else should I do at this point, because the patient was still like not kind of satisfied. So like, if you could guide me, how should we proceed forward, because I offered everything, sympathy and then medication as
Nothing.
well.
I'm sorry is enough. I'm sorry
Okay.
for that is enough. If the
Okay.
patient said, I'm feeling unwell, oh, I understand, and I'm sorry for that. I'm sorry for your pain. This
Yes.
is enough. This is, you will take the mark of sympathy.
Okay.
We don't much expressions for sympathy. Only I want to get that you are feeling the pain. You
Yes.
understand me? Still,
Yes.
the patient will vomit twice in the station. She
Yes.
lost 2 minutes from the station vomiting.
Yes.
So no time. He want to how you communicate. How will you communicate? If you communicate well, he will give you the mark.
Yes.
Okay. The
Yes.
second thing that I noticed that you give the patient, do you drink or smoke? Which one she will answer, drink or smoke?
Okay. So I
Don't
have.
give her multiple options. Do you
Okay.
drink? No, she will answer. Do you smoke? She will answer.
Okay. Okay. Sure.
Okay.
Okay.
Regarding the information gathering, you analyze the patient complaint. What is the pain, when, why, like this. But this patient post-operative, you ask about the wound. You ask about the cause of the surgery. But you miss a very important point in the information gathering. What's her obstetric history? This patient making laparoscopy for fertility reason.
Yeah.
Very important point in information gathering.
Yes.
You ask her only for about LMB, previous surgeries. You mentioned later on about operative news. Operative news, one of the information gathering you will be assessed for. You mentioned it, but later on.
Or what?
Operative notes.
Yes. Operative
You
notes.
should go through her operative notes.
Yes.
Okay.
Yes.
What do you think? This patient needs admission or no?
Yes. Of course, this patient
Okay,
need.
this is a major safety point. You inform your consultant.
So I said it would be a multidisciplinary team approach. We will
No.
involve on.
Multi-disciplinary team in management. But this
Okay.
patient now post-operative came unwell. You are suspecting ureteric, and you will do admission for this patient. You will not inform your consultant. Again, you forget
Yes.
your consultant.
Yes.
You are not. You are ST5. You are not managing alone.
Yes.
You understand me? You will know
Yes.
everything about the case, but you find yourself, you will not pass in safety.
Yes. Yes.
You understand me?
Yes.
What about ibuprofen? Why ibuprofen mentioned here? This
That
patient,
can.
her temperature 38.
Yes.
Anything suspicious?
Yes. She can have kidney injury as well.
Okay. What about ibuprofen in kidney injury?
Yeah. But she has right loin pain.
Okay. What does this mean?
So there could be possibility of kidney injury. The patient can have.
Okay. What about ibuprofen? Ibuprofen will deteriorate the kidney injury.
So stop the.
Major safety point. Okay.
Yes.
If any medication comes in the task, you should suspect this is a safety point.
Yes.
Generally, in all tasks. Okay.
Yes.
Okay. If you suspect any sepsis infection in that
Yes.
patient,
Yes.
what you will do?
Sepsis 6 per bundle.
Okay. What you will do? What is the most important thing?
So start oxygen, take cultures, antibiotic, broad spectrum antibiotics.
Yes, the most important thing here to start antibiotic.
Yes, and then serum lactate would be.
Serum lactate will not affect the patient life, but antibiotic, if you didn't start, may affect the patient life.
Yes.
Okay.
Yes.
You understand me?
Yes.
How many important points you missed, And
Yes.
finally, you know the diagnosis, but you missed.
Yes.
Okay, don't
Yeah.
please. This is one of the my general comment on your performance. In all stations, even with Dr. Farwat, you didn't check the patient understanding. Don't forget in between, tell the patient, are you following me? Do you understand me?
Okay.
How does it sound to you? You understand? This
Yes.
is very important. This is also make a good relationship between you and the patient.
Yes.
Oh, you okay? You get my
Yes.
points?
Yeah. So in here, like what when I see here, like there are differential diagnoses, ureteric injury, there could be evolving acute kidney injury, sepsis. So like in management, how should we approach it then?
No, this patient is not asking about the management. And even if she asks about the management, you will tell her, actually, in your case, we don't have any final diagnosis, but we will do blah, 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 blah to reach our diagnosis because our differential diagnosis or we are suspecting that maybe the tube that connect to your urine bag, there is maybe some injury. And this is can appear from your pain. Understand? And maybe there's a urine bag itself injured during the operation. This may happen. There may be also about injury. You understand me? And we'll do
Okay.
some investigation because there is maybe some infection in your bloodstream, and this is sometimes it will be serious, may affect your life. So we'll need to do some investigation and we'll do it urgent. So you need admission at the moment. I will inform my consultant about your condition, then we will start the procedure.
Okay.
As it may affect your kidney, we will stop the medication ibuprofen and we will start antibiotic. You understand? I give all the management in one sentence.
Okay. Okay. So basically, we have to briefly talk about all the differential and
No,
management.
briefly, yes. Briefly, I will give her what is in my mind, and after I reach the final diagnosis, we will manage accordingly.
Okay. Okay. Yeah, because like I thought it's difficult to like explain everything in just
No,
4 or
don't
5.
explain everything.
Okay.
For your patient in real life, you will explain everything? No.
Yeah, and also her BP was 80, 45. So, like it was difficult because patient we need to resuscitate the patient first before going with the management.
Patient is talking to you. She is hypotensive, but she's talking to you. She's stable.
Okay.
She's not collapsing.
Okay.
Understand?
Okay.
Okay. You please take this notes, write these notes. These notes will make you boss.
Yeah, inshallah, inshallah. Yeah, that's why. Thanks for all your feedback. I really appreciate it.
Thank you. Now you get break about 20 minutes, not 15 minutes, 20 minutes.
Okay.
Okay?
Okay. 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 Thank you. Yeah.
Thank you.
After these difficult cases, I need to breathe, I think.
Okay. Thank you. Thank you. Good luck.
Okay. Thank
Good.
you. Thank you.